أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم. First of all, thank you for inviting me on this very pleasant occasion to join you. Let me congratulate Dr. Zeeb and our team for all the efforts to make this project a success. Everything's been said, so there's not a lot to say, but I have a few observations which I thought I will share with you. There isn't any other department with so many names as AMU. There are so many names depending on which country you are working in. And this includes the acute assessment unit, acute admission unit. And I think it is really important to be aware of what the meaning of these different words are. Clearly, this is a concept which arose from need and urgency and desperation, and I think it was probably UK where it originated. And the reason for that was to somehow reduce the number of hours patients were waiting in the emergency department. And I think in different countries, the supervisor in AMU can be from medical ward, they can be from emergency ward, and they can be from critical care ward as well. So it just shows the collaboration of different teams is so important. The whole idea was to admit, it's basically just as one of the speakers said, it's a gateway or a bridge between emergency department, wards in UK with GPs, and here I can see from the outpatient department. And so it is never the reverse. So the wards are not allowed to admit patients to AMU, but the flow should be that the patient is admitted from emergency ward, they are stabilized, investigated, and then they move onwards. It's a transit. It's not a unit for the patients to stay indefinitely, and it's clear from the word AMU, acute medical ward or unit. And how long should a patient be staying in this ward? And I think that is really important as well. I think we have to make sure that the flow in that direction from emergency to AMU to wards is non-obtrusive, that people cooperate with AMU, and the patients are not in the AMU unnecessarily, because what will happen? It will develop a backlog, and so the patients cannot then be admitted to AMU because there is a limit to how many beds you can have in any unit. It's impossible to have a number which is like in thousands or even in hundreds. So 48 hours is normally the time that a patient should stay in AMU, ideally less than that. Also, no matter how many specialists you have in AMU, there is a limit to the knowledge we all have. We cannot have knowledge about everything. So it is really crucial for the different specialties to cooperate with AMU in the matter of diagnosis, in the matter of management, and then also making sure that they take the patients to their own respective wards. And no matter what the situation is, I think we have to make sure that we have beds available for these patients. Now, the two observation points that I have is the criteria for admission and the criteria of discharge. And it is not just the AMU that I'm really addressing here. It is every department we are talking about. I think the criteria of admission and discharge is very lenient. I think it could be toughened up, it could be made more stricter. And there is no need for patients to be lying in the ward unnecessarily. I, as a surgeon, I'm sorry I'm taking a bit of time, but I think it's really important. I'm a surgeon by profession, and I believe in enhanced recovery after surgery. And the whole idea of enhanced recovery after surgery is similar to AMU, that the patient should be treated, investigated, and then they should be discharged as soon as possible. Why? Because hospital is not a healthy environment. Hospital is only for sick people. And quite often these sick people, when treated, are in the phase of transition, and that transition should be at home. It should not be in the wards. especially for surgical patients. If I do a major operation on a patient, the patient's immune system is very low. So they will pick up anything from anyone, even from their own doctors, if they stay unnecessarily in the hospital. So my request really is for every department to make sure that you stiffen up your criteria for admission and discharge. Now that we have completed 1 year, and I'm sure we had a lot of teething problems, and I'm sure there's still a lot of problems, as one or two other speakers suggested. I think it is time for us to take stock, to think about what the problems were, pencil them down, and meet amongst the different specialties in a very nice way. And let's see what we can do, everyone we can do to try and help you to streamline AMU. And I hope that AMU is going to be a leader in innovative concepts, basically. And why not we have similar surgical thing. And one thing that comes to my mind is day surgery unit. We are struggling, we're trying our best to develop. So we have the elective cases away from these emergency cases, so there's not a mix of elective and emergency. Thank you very much.